Thank you very much. The next speaker is once again Brandon Erickson. He's going to speak about anatomy and role of the superior labrum and biceps.
For this talk, we're going to talk mostly anatomy. We'll talk a little bit of function, and then I'll leave the management up to the next two talkers because they'll tell you a little bit more about that. From a game plan perspective, like I said, we'll do a little bit of anatomy, talk about different types of slap tears, classifications, and then kind of the function of the superior labrum and the biceps based on EMG versus biomechanical studies. So the labrum, we won't dwell on this, but basically the function of the labrum is to deepen the glenoid cavity, right? As Dr. Sagaya mentioned before, the glenoid is very small, humeral head's very big. To keep the humeral head centered within the glenoid, you have to have some kind of bumper, and that's the function of the labrum. It also allows the long head of the biceps tendon to take its origin from it superiorly. Sometimes there are slight variants that we'll discuss in a second, but the majority of patients, the biceps takes its origin from the superior labrum. Again, it also functions to lubricate the glenohumeral joint, okay? And when we talk about the biceps tendon itself, there's a lot of stuff on this slide, but the main thing I want you to take home from this is that in order for the shoulder to go through a normal range of motion, the biceps needs to be able to move about 19 millimeters. So it has to have some excursion as you take the arm through your range of motion, or you're going to get stuck and you're going to have pain if it's not moving properly. When we talk about slap tears, we have to think about why they occur. So there's two schools of thought as to why slap tears occur in our overhead throwers. It was first described by Dr. Andrews in the 80s, and Dr. Schneider then kind of began the classification of them, which now there are up to 10 types. You can certainly fall on your shoulder and have a compression injury for your shoulder, but that's not really what our baseball athletes are undergoing. There's two real main issues with our overhead athletes. One is there's some eccentric activity of the biceps during the deceleration phase. So you can get a traction injury to the biceps superior labral complex as you're trying to decelerate the arm, as the biceps tries to prevent the shoulder from being thrown off of the body when you're decelerating after you let go of the ball. The other way is, and what you're seeing here in this video, is a peel back lesion. So as the shoulder is not functioning properly, as Dr. Sagaya mentioned, as there is micro motion and things begin to translate because posterior capsular structures are tight, anterior structures are lax, actually the humeral head starts to ride up and can actually start to lift the labrum off of where it attaches to the glenoid. And so it's one of these two etiologies that usually cause the majority of our slap tears in our throwers. And we talk about the different types of slap tears. There's, of course, type 1, where there's just some mild fraying. There's a type 2, where you start to see the biceps labral complex peel off. You can start to see the bone off of the cartilage surface when you're looking at this intraoperatively. You can see a meniscoid variant with the biceps anchor still intact. And then you can see the biceps labral complex taken off with an unstable biceps anchor. And the treatment kind of varies based on what type of lesion you have. When we look at slap tears, we're really talking about type 2 slap tears in our overhead athletes. And you can see here in this video, this is kind of what a type 2 slap tear looks like. The superior labrum is unstable. The biceps anchor is still attached to the superior labrum, but it's peeling back more than it should. It's translating more than it should. One of the issues with slap tears, though, is that we're not very good as surgeons at classifying what type of tear it is. If you look at this study that was done several years ago, the basic take-home point from this study was that surgeons had a really hard time distinguishing normal shoulders from type 2 slap tears, and then some of the other variants as well. One of the other issues you have to think about is the anatomic variance in the shoulder in regards to the biceps and the labrum. So if you're looking at a shoulder and you see, kind of an absent anterior superior labrum, a very thick cord-like middle glenohumeral ligament, you have to remember that's not really a slap tear, that's just a Buford complex. So the wrong thing to do would be to start to tack things back down because you'll over-tighten the shoulder. When we talk about why it's important to discuss slap tears, it's really the last 10 or 15 years that these have been talked about more and more. And specifically in the United States, these aren't throwing athletes, these are just general patients. But you can see here the number of slap repairs is going up dramatically in the United States, or at least it was for a certain period of time. And these can either be treated, at least the way we do it in the States, is usually either with a slap repair or a biceps tenodesis. The number of slap repairs was going up for a while, but then we started to see some issues with the way patients were doing with some shoulder stiffness. And so when we looked at a database at Rush, we actually saw that the age of patients having slap repairs was going down and that the number of biceps tenodesis was going up. Again, this is not for overhead athletes. This is just the general population. So let's talk about the role of the superior labrum and the biceps in the overhead athlete. Well, if you look at some of the data, it's actually pretty conflicting. If you look at the EMG data, it says the biceps probably has a minimal role in the overhead athlete. Whereas if you look at some of the biomechanical studies, it suggests that the superior labrum and the biceps complex function more as a secondary stabilizer in the overhead athlete. If you look at this study that was done back at Rush, what they did was they created slap tears, anterior and posterior to the biceps labral complex. And what they found was that as they put the shoulder through a range of motion, as you can see here, the anterior slaps and the posterior slaps, there was more translation within the glenohumeral joint as they started to take the shoulder through a range of motion with these slap tears that were there. So this was actually true laxity. This was not pseudo-laxity. These were statistically significant differences. Once you had the slap tear, so you have a slap tear, you take the shoulder through a range of motion, it moves more than it's supposed to. So this gets back to Dr. Sagai's point of keeping the humeral head centered. So it seems like the humeral head's not being properly centered. When you look at some of the EMG studies that have been done, this study looked at comparing normal pitchers to pitchers who had a biceps tenodesis and pitchers who had a slap repair. And if you look at the EMG data here, it'll tell you that actually the biceps tenodesis functioned more close to the normal shoulder than the slap repair did, suggesting that maybe the intra-articular portion of the biceps doesn't have a huge role in the overhead athlete, as these were players they put through motion analysis and video analysis and looked at the EMG activation of the biceps during the pitch. So the EMG data here would suggest that the biceps may not have a significant role. The issue is when we start to perform a biceps tenodesis on professional athletes or overhead throwers, actually the results are not good. When we looked at the Major League Baseball database, we saw that, unfortunately, the results following a biceps tenodesis for a slap repair in Major League players were very poor, specifically in pitchers. They were okay in position players, but in pitchers, the results were not very good. If they did get back to playing, they actually didn't see a decline in their performance, but that was only a very select few of them that were able to get back. But we still haven't really figured this out yet, because if we look at the outcomes of slap repairs, they don't do great, at least in our athletes either. And the question is, do we make them too tight? Are we taking what was compensatory pathology, so not really pathology, but adaptive changes, and we are then tightening them up and we're getting rid of this adaptive change, so we're actually introducing some pathology into their shoulder. Maybe the labrum doesn't heal well. There can sometimes be some hardware complications. That's largely been mitigated with the use of knotless anchors nowadays. And sometimes the biceps being in the shoulder can still be a pain generator. So then you think about, well, what if you do a slap repair and a biceps tenodesis? So you release the biceps, you fix the unstable superior labrum, and you also tenodese the biceps. Unfortunately, this actually wasn't great. This was, again, a study from Rush, and if you look at the biceps tenodesis plus the slap repair, they had more pain than just the isolated biceps tenodesis or isolated slap repair in and of themselves. So probably not the answer in our overhead athletes. So in summary, you have to remember the superior labrum and the biceps very intimately related. The EMG data that you look at will suggest that the biceps really does not have a very large role in our overhead athletes, but if you look at some of the biomechanical data, it makes sense that the biceps, specifically the intra-articular portion, functions to keep the humeral head centered within the glenoid cavity, and as we know, that's very important in our overhead athletes. The other issue that we have to keep in mind is that we have to make sure we properly differentiate between adaptive changes in a pitcher's shoulder and what's pathological. And I think we're still learning at that, because I don't think we do necessarily a very good job at that. And if we don't, we wind up hurting these athletes once we start to operate on them. Thanks.
Thank you.